हो गया स्टार्ट हो गया Assalamu alaikum ji, good morning. Saturday today, so no lectures tomorrow. It's always a good news. My name is Dr. Azhar. I'm one of the physician and nephrologist. I think today's our topic is regarding calcium hemostasis. There's not much about it though, so I can't see that I can spend an hour on calcium hemostasis, or you can listen about calcium hemostasis for an hour. So what I've decided is we'll do some MCQs, and then we will study around the MCQs, and then in the second part of our lecture we will do the calcium hemostasis. Okay. Okay. Let's do these questions. So I'll go through with you. You can read, or you can take snapshots as well of these questions. A 24-year-old woman presents with wheeze and breathlessness to the emergency department. So young woman with breathlessness, known to have asthma, and has 2 inhalers from her GP, beclomethasone and salbutamol. She has been using a salbutamol inhaler multiple times per day in the first few days without relief. Her normal best peak flow is 480. She smokes 5 cigarettes a day. So this lady who is asthmatic is on 2 regular inhalers, salbutamol and beclomethasone, the steroid inhaler, and a beta-2 agonist, presented with breathlessness and wheeze. In the last recently, she hasn't found any much control of her asthma. Her best peak flow was 480. She's talking in broken sentences, so she's unable to talk in full sentences, so she is short of breath. Her peak flow is very low, less than 180, which is 37.5 was predicted. 98% saturation on air. She's tachypnic. She's bilateral wheeze, and she's using accessory muscles of breathing. There is no signs of consciousness, alteration, exhaustion. So essentially, this girl has got a reduced peak flow. She's asthmatic. She's talking in broken sentences. So now, in asthma, you divide into acute severe asthma, moderate severe asthma, or mild asthma, which is based on some sort of objective findings. So what would be the first step in the management plan? So what is your first step in your management plan? So you give back-to-back salbutamol inhalers, intravenous magnesium, and big to the medical high dependency units. So you think this is a severe asthma. So poor air entry on auscultation, silent chest, low peak flow, tachypnic. So this is severe asthma. We'll come back to these answers. So 48-year-old woman presents to the emergency department with a 48 hours history of productive cough. So she was coughing up sputum. She's got fever and she's got breathlessness. Previous history, she takes lisinopril for her hypertension. She is paraxial, slightly tachycardic, not tachypnic. Saturations are low. Abbreviated mental stress score is 10 out of 10. Crackles in her right lung, otherwise her stomach examination was unremarkable. She's got right lung based crackles with hypoxia on room air, and she's paraxial. She's got a raised white cell count. She's got a raised urea, not normal urea, and her creatinine is also normal. CRP is high, and you see a chest X-ray, she got right basal pneumonia. So if you do a curve score, CURB, she's not confused. Her age is not more than 60. Her respiratory rate is not high. So, and her urea is normal. So, this could be curve 1. So curve 1, you give only single antibiotics. And curve 2, you give dual antibiotics. If you do the curve scoring, then she is a curve 1 and you give this. So next questions. So you're reviewing a 76-year-old lady who has a diagnosis of heart failure in your outpatient clinic. So heart failure patient. So she reports that her exercise tolerance has reduced since her last clinic appointment 3 months ago. Hypertension, osteoporosis, hypercholesteremia, and she's currently taking ACE inhibitors, furosemide, torvastatin, alendronic acid for osteoporosis, maximum tolerated dose of ramipril and bisopril. So eating edema. Her blood pressure is okay. Her heart rate was just slightly bradycardic. Her ejection fraction on echo was 30%. All her blood tests were usually normal. So what would you do? She's only on bisoprolol on maximum doses. She still have got shortness of breath. And her exercise tolerance is decreased. She has pitting edema of both ankles. So you probably will give some spiramide, which has got evidence to suggest in heart failure patients, because she's already on beta blocker and either you can give a spironolactone or you can start ivabradine. COPD patient with sudden onset of right-sided chest pain with shortness of breath. So what is this? He's tachypnic, hypoxic, and reduced air entry. So if you see this lung is fine, you can see the things, the lung markings. But here you can see the border of the lung, this one. And this is all pneumothorax. So just admit to the hospital. So again, not all the pneumothoraces have to be drained. So it's a 3 centimeter pneumothorax. So it's just more than, I think, 2 centimeter, then you will do a chest drain. 76-year-old man with admitted to the medical take of COPD exacerbation and treated with a regular nebulizer, oxygen, and steroids. On second day, doesn't seems to be improving. He was tired, he was tachypnic, he was hypoxic. He has bilateral wheeze on chest auscultation. So hypoxic patient and tachypnic. I'm tired. So what you can do is you can increase his oxygen therapy to maintain between 88 and 92, and then obtain arterial gas blood pressure, arterial gases. You've been asked to assess a 38 years old woman who's been referred to the medical team with acute breathlessness. She is tachypnic, broken sentences, hypoxic, tachycardic, blood pressure okay. What would you do the first for this lady? High flow oxygen using a controlled. No, you just give high flow oxygen with non-breathing mask. So oxygen therapy. So high flow oxygen, so acutely unwell patient should be assessed with the ABCD approach. Okay. High flow oxygen should be administered initially in critically unwell patients pending further investigations. Hypoxia leads to an organ damage, and the British Society guidelines on emergency oxygen use recommend this should be treated without delay to maintain oxygen saturation of 94%. Okay. So hypoxia you have to avoid. Pulse oximetry should be available in all acute settings. Okay. So you have a certain targets for oxygen saturation. So your PD it is 88 to 92, and you titrate your oxygen as per it is. So in COVID-19, what we do need to the high flow nasal oxygens should not be used because that can cause outbreak, that can cause environmental contamination. Okay, let's talk about physiology of breathlessness. The sensation of breathlessness is a dyspnea. It is caused by a combination of stimuli activating multiple neurological pathways. So there are peripheral and central chemoreceptors which are sensitive to hypoxia, hypercapnia, and acidosis. Then there are pulmonary stretch receptors. Then there are vascular stretch receptors, airway mucosal sensation. Okay. So physiological change is detected through peripheral and chemoreceptors, pulmonary stretch receptor, vascular stretch receptors, and airway mucosal sensations. So these are certain high flow oxygen with otherwise with non-breather masks. Humid high oxygen for patients taking high flow oxygen for longer period of time or those who experience discomfort. So Venturi masks are delivery of specific oxygen concentrations. These are the things. So these are the facial mask. And these different colors are depending upon different concentration of oxygen, 24, 28%, 32%. These are the things. So breathing pattern disorder, dysfunctional breathing are terms to describe a range of breathing condition without an organ. So dysfunctional breathing, some people are sort of a disproportionate dyspnea, or they are anxious and they hyperventilate. So question 2. So Miss W is given high flow oxygen through a non-rebreather mask, and oxygen saturation improves, but tachypnea also improves. So she recently returned from holiday. She has no significant past medical history. She has never smoked. So most likely differential diagnosis of this lady. She returned from holiday. She may well have a community-acquired pneumonia, and she may well have a pulmonary embolism. That's partially correct. Okay, let's see. Oh, I should have actually I've seen the X-ray, didn't we? The sudden onset of breathlessness and chest pain are most consistent with the diagnosis of pneumothorax and a pulmonary embolism. The recent long flight, the onset of community pneumonia less. Types of pneumothoraces: traumatic, spontaneous occurs while in healthy people, and secondary is the pre-existing lung disease such as COPD. So risk factors: hospitalization, cancer, chronic conditions, obesity, pregnancy. They all are risk factors for pulmonary embolism or DVT. We suspect that pneumothorax pulmonary embolism are the most causative also should know. What's the initial test you would perform to distinguish between these two causes? Chest X-ray. Chest X-ray will distinguish between these two causes. So it's a pneumothorax, it will show up. So performing a chest X-ray is the most simple way to distinguish between the two conditions. Okay, you do a chest X-ray, you see whether it's a pneumothorax or no. You may not be able to see a PE on a chest X-ray though. An erect inspiratory PA view. We've seen the pneumothorax X-ray, didn't we? So there are two-level Welch scores, which estimates the probability of the PE. And these are the points. If the patient is tachycardic versus less points, 1.5. Immobilization, 1.5. Previous DVT, 1.5. Hemostasis, 1. Malignancy, 1. So you do a score. So PE is likely if there is more than 4 score, more than 4 points. PE is unlikely if it's less than 4. Okay, so if you have a score of more than 4, your diagnosis of pulmonary embolism is more likely. If you have a score of 4, you do a D-dimer test. If it's raised, PE is likely. If it's normal, PE is unlikely. If your score is less than 4, then you should consider alternative diagnosis. So CT pulmonary angiogram. So that's how it looks. So if you see, this is a pulmonary trunk, and that is a thrombus, the filling defect. This is the black. So that is a thrombus. This is a contrast, which is the white. So lower density than the contrast. The absence of contrast in the pulmonary tree. And you can see the right ventricular interventricular septum thickening. So what's the treatment of pulmonary embolism? So mainstay of treatment of pulmonary embolism is anticoagulation. Okay, we should continue for 3 months. Apixaban and rivaroxaban are used as treatment for pulmonary embolism. These are direct oral anticoagulant. Apixaban and rivaroxaban, DOACs, are licensed to use single drug approach. If neither rivaroxaban is suitable, NICE advises for treatment with low molecular heparin for at least 5 days, followed by dabigatran or edoxaban. An assessment can be made in 3 months, a 3-month point at whether to continue the anticoagulation or not. Is it a massive PE? You use thrombolysis. Okay, I'll let you read this question through first. So you request a chest X-ray. You ask the nurse to draw the blood for usuals. So after the nurse calls you, the patient deteriorated significantly. Saturations become very low, very tachypnic, hyperresonant to percussion. The GCS is slightly swollen. The blood pressure become low. Heart rate is tachycardic. So this patient, who we were thinking that may have got a pulmonary embolism, become very hypoxic. Trachea is deviated on the left. So all these findings are looks like these are the tension pneumothorax, the deviation of the trachea and the tension pneumothorax. You do an emergency thoracocentesis. The patient has the signs of tension pneumothorax. What are the signs of tension pneumothorax? Unilateral reduction in the air entry, hyperpercussion or hyperresonance to percussion, tracheal deviation, and cardiorespiratory compromise. So tension pneumothorax is an immediate life-threatening emergency. You need to decompress the lungs immediately. Take a large bore cannula and insert in a second intercostal space. Just insert a large cannula on the right side. Suitable sites for needle decompression are the second intercostal in mid the fourth intercostal space between the anterior axillary and mid axillary lines, and the fifth intercostal space between the anterior axillary and the mid axillary line. A chest drain should always be inserted following the decompression first instantly with a needle or a large bore cannula. And reversible pathologies you identify during the process and should be treated immediately. So the key point here is that if the tension pneumothorax is a medical emergency, you don't wait all the kit to arrive for a chest drain. You put the large bore cannula, insert the large bore cannula and second intercostal space on the right side where the pneumothorax is, in the mid-clavicle line, either right or left where the pneumothorax is. Okay, so the British Society recommendation for the management of spontaneous pneumothorax. Okay, sorry. Something else happened actually. Okay. Let me get some help. I think the screen gone off. I'm just going calling the technician. Yeah, ये screen off हो गई है. मैं image save कर रहा था. ठीक हो गया. Okay. So this is sort of an algorithm of the management of spontaneous pneumothorax. On urgent needle decompression, a hiss is heard as the needle is inserted. Immediately feels better, respiratory rate improves. You arrange a chest drain and subsequently you drain the chest. Primary spontaneous pneumothorax occurs in healthy patients without underlying disease. Secondary happens in the COPD. Secondary is more mortality and more morbidity as compared to primary. So management of spontaneous pneumothorax. So if bilaterally hemodynamically unstable, proceed to chest drain. So age more than 50, significant history of smoking, evidence of underlying lung disease. No, which is a primary pneumothorax. If it is yes, it is a secondary pneumothorax. Size more than 2 centimeter or the patient is breathless. Aspirate. Size is not no more than 2 centimeter. You consider discharge and review in 4 to 8 weeks. After aspiration, size is less than 2 centimeter, and you consider discharge the patient. After aspiration, size is not less than 2 centimeter. You consider chest drain. All the secondary pneumothoraces, if the size is more than 2 centimeter, you consider chest drain. If the size is less than 2 centimeter, You aspirate and it becomes reduced the size. If size is 1 to 2 centimeter, no. Admit for high flow oxygen. So, essentially, it depends upon how big the pneumothorax is. You aspirate all the pneumothoraces who are less than 2.5 centimeter and more than 2 centimeter. You decrease their size and then you discharge them and see an OPD. And secondary pneumothoraces depends on the size. If it's a small pneumothorax, you do an aspirate, you give high flow oxygen. If it's a large pneumothorax, you do a chest drain. Okay, after 24 hours of being drained in situ, the radiologist tell you the drain is not working and could you read with the patient. The patient appears well. Drain is swinging, but there is no bubbling of the underseal. Her chest is clear. An equal air entry. So it is swinging, but it is not bubbling. So there is probably no air. So you arrange a repeat chest X-rays to see that you have got enough. So swinging drain means that it is in the pleural space and is not blocked. It is not blocked. We will tell you that currently it is not draining any air. It is very important to reassess the chest X-ray, see the expansion of the chest, and remove the drain. Seldinger drain, chest drain insertion. Okay, the chest X-ray show complete resolution in pneumothorax, so the chest drain is removed. So admit to return to hospital. There is increasing breathlessness. Air travel should be avoided until the full resolution is confirmed in the chest X-ray. (28% of recurrence of following primary pneumothorax, greatest in the first 2 years. So there is a recurrence chance. And you don't do it, scuba diving is prohibited. So now Mr. W remains stable the next 24 hours. There is a complete resolution on the chest X-ray. So what are the key points in this? So patients presenting with acute breathlessness should be assessed and managed according to the ABCD approach. If the diagnosis of pulmonary embolism is not obvious and you consider risk factor for thromboembolism, we have seen a CTPAs with a pulmonary embolism as a filling defect. So you give anticoagulation for 3 months for a PE. And if the patient has got a right heart failure and a massive PE and in a shock, or in addition, inotropic support or ventilatory support. Tension pneumothorax is a life-threatening emergency. You do a needle aspiration followed by chest drain insertion. Not all spontaneous non-tension pneumothorax need intervention. A chest drain should be considered. Following unsuccessful spontaneous pneumothorax aspiration, you do a chest drain. If it's more than 2 centimeter, in secondary pneumothorax, if it's more than 2 centimeter, you do a chest drain as the primary procedure. And if it's 1 to 2 centimeter after the failed needle aspiration, you do a chest drain. Okay. Next question. So 69 years old man, Mr. D, presents to the emergency department acutely short of breath. Okay, he's well known to the hospital because of his COPD and regularly attends the hospital with exacerbation. He cannot speak in full sentences. His lips were cyanosed. He is hypoxic. He is wheezy. He is tachypnic. His capillary refill is less than 2. He is dry dehydrated. His heart rate is high. His blood pressure is fine. And he's aparaxial. So apply controlled oxygen. Reading a chest X-ray, perform an ABG. All are do good. But apply controlled oxygen for a Venturi mask. Okay, so apply controlled oxygen via Venturi mask. While hypoxia can kill, there is a risk factor of hypoxia and COPD leading to hypercapnic respiratory failure. Control oxygen should be applied with pending availability of arterial blood gases measurements or X-ray. So there's a medical emergency of stridor. Stridor is a single point obstruction of a large airway. So you see a harsh monophonic inspiratory sound. Wheeze is a polyphonic expiratory whistling sound. So harsh stridor is a harsh inspiratory sound and wheeze is a harsh expiratory sound caused by small area obstructions such as patients in chronic exacerbation of COPD or asthma. So just remember the difference between stridor and wheeze. Okay, so we are dealing with the COPD patients. We gave the COPD patient to oxygen to maintain the saturation between 88 and 92. So Mr. D is administered oxygen via 28 Venturi mask. He is giving you a history of increasing short of the breath for the last 48 hours. He was diagnosed with a COPD 7 years ago and currently uses a formoterol budesonide combination inhaler. He is not giving any relief from salbutamol and he is taking oral prednisolone from yesterday. His ABGs showed that his partial pressure of oxygen is low, he is hypercapnic, he has got a type 2 respiratory failure with respiratory acidosis. So you give salbutamol and ipratropium administered via a nebulizer. Okay. The short-acting inhaled beta-2 agonist and short-acting antimuscarinics are recommended as initial bronchodilator therapy. Okay. Systemic cortisone can also improve the recovery time and improve oxygenation. NICE recommends oral steroids, 30 milligram for 5 days. So there was a clinical trial, which is a reduced trial, which was happened in a reduction in the use of corticosteroid and exacerbated COPD. So NICE recommends that patients who are hypercapnic and acidity should have regular clinical assessment, intermittent arterial blood gases, and have optimal 1 hour of medical therapy before you consider an IV. If the patient after an optimal medical therapy remain acidotic or hypoxic, you need an IV. NIV, not continuous positive air pressure, is recommended for the treatment of hypercapnic respiratory failure. So bilevel ventilation support with different inspiratory and expiratory pressures. So it gives inspiratory pressure to support inspiration, which is known as IPAP, and an end expiratory pressures, CPAP is important in the treatment of hypoxia. So oral corticosteroids are used in preference to intravenous corticosteroids, and intravenous theophylline are reserved after the patient has not been improved on a nebulized therapy. So administration of nebulizer is not considered a viral aerosol generating procedure by Public Health England. Let's read a bit more about an IV. So it can be distressing and uncomfortable to the patients who have this for the very first time. It should be used by the trained nurse practitioner. When starting an IV with COPD patients, ABG's measurements, chest radiograph, respiratory, reversible causes should be sought out. So, Mr. D has started on back-to-back therapy, salbutamol and ipratropium therapy via nebulizer, and there's mild improvement in his chest X-ray, in his V's. Test is performed. We didn't show any supraimmunosal infection. So ABGs were done. He was unconscious in NIV. Set up 22 meter of mercury inspiratory. IPAP is 22 and 6 is the expiratory. We perform an ABCD assessment. Patient airway, she is not tachypnic. Saturations were 91 with some V's. Blood pressure was fine. GCS remained low. You do perform an arterial blood gas measurement. Which is not correct. So what you do? Showing adverse features such as the normal mechanism was not working. In this situation, urgent anesthetic review should be considered for intubation. So this patient has got hypercapnia, and that is is not working, carbon dioxide is not removed, the patients develop hypercapnia, and then the patients can have decrease in consciousness. Okay. So I think I'm going to finish this module here. Let's close this module. I'll get a new share. Okay, so let's discuss about calcium homeostasis. Okay. So 99% of the bodies of calcium is in the bone and calcium phosphate compounds. So calcium is mainly present in the bones, and in the bones it is present in a calcium phosphate combination. So they're very important, calcium ions. So they are important. They're a part of the bone and teeth matrix. So their levels regulate the muscle excitation and their contraction. It also regulates the cardiac function. Calcium levels are required for nerve function, for metabolites or metabolic enzymes, and it also serves as a cofactor for blood clotting proteins. So calcium is very important roles. Calcium has got a very important roles. So calcium homeostasis. So how does calcium get regulated? So when the calcium gets low, so parathyroid hormone gets high. So release of parathyroid hormone will do three things: decrease calcium in the urine, increase vitamin D, which causes increased calcium absorption, and efflux of the calcium from the bones, and causes the calcium in the blood to become high. So that's how the calcium homeostasis maintained. So ionized calcium. So ionized calcium is considered an biologically active form of calcium, and it is a part of the component that regulates PTH. So total calcium is made up of three components: protein-bound calcium, ionized calcium, and calcium that is complexed with anions, such as phosphate, citrate, bicarbonate, and lactate. So calcium which is protein-bound, calcium which is ionized, and calcium which is bound to other compounds, other anions. So this is a thyroid gland, and that's a parathyroid gland. So parathyroid glands are found in all breathing vertebrates. The parathyroid gland acts to increase the serum calcium by production of parathyroid hormones. So they are receptors for ionized calcium. Small increase in the ionized calcium will decrease the parathyroid hormone secretion. The primary function of PTH is to elevate the serum ionized calcium concentration. So that is the primary function, is actually to increase the concentration of calcium ions, which is accomplished by stimulating bone resorption, bone dissolution, increased resorption of calcium in the kidneys, decrease renal phosphate reabsorption, stimulate the activation of vitamin D in the kidneys. As I told you, calcium absorption in the small intestine gets increased as well. Hypercalcemia. Ionized calcium has a negative feedback on parathyroid hormone production. Normal total blood calcium levels is 12 milligram. Clinical signs appears when it is around 15. Hypercalcemia symptoms. What are the symptoms of hypercalcemia? Generalized weakness, lethargies. It can be like ECG abnormalities, muscle twitching, anorexia. Hypercalcemia causes, it can be caused by a malignancy, it can be caused an Addison disease, it can be caused by the primary hyperparathyroidism, antigranulomatous diseases, bone cancers, bone infections. They all can raise the calcium levels. Immobility can raise the calcium levels. PTH analysis. PTH degrades very quickly. So the radioimmunoassay, air mass per human PTH. So total calcium is routinely paired on chemistry panels. So humoral hypercalcemia of malignancy, where the parathyroid hormone releasing peptide tracks patient secretes, and that causes hypercalcemia, especially in lymphosarcoma, adenosarcoma, adenocarcinomas, and multiple myeloma. Hypercalcemia of hyperthyroidism usually was by one of the adenomas. You surgically remove all the enlarged thyroid or parathyroid glands, and hypercalcemia occurs after the surgery. So, how do you treat hypercalcemia? Fluid therapy, you give IV saline, normal saline, and you give a furosemide. So, this is called as saline diuresis. Steroids also reduces the calcium absorptions, and you can give a calcitonin hormone to treat the hypercalcemia as well. So hypocalcemia. So hypocalcemia is a common biological abnormality. So hypercalcemia can happen in a renal failure, can happen in a pancreatitis, and any antipresoethylene glycol toxicity. Hyperparathyroidism can cause hypercalcemia. Renal failure can cause hypercalcemia. Pancreatitis can cause hypercalcemia. Hypercalcemia, muscle fasciculation, tetany. Physical examination. So treatment of hypercalcemia, you treat the cause of the hypercalcemia, especially if it's a renal cause, you give vitamin D, you give active forms of vitamin D, you treat with the calcium supplements as well. If the patient has got ECG changes and hypercalcemia, what are the ECG changes in hypercalcemia? The most common ECG change in the hypercalcemia is QT prolongation. So all the patients with hypercalcemia should have their ECG. So these are the bits of hypo and hypercalcemia. I'm going to leave here, and if any questions, you can ask for me. If there are any questions, please feel free. Any more questions from you guys? Okay, I'm going to stop sharing it and finish it off.